professional. Okay, well, welcome everyone to another edition of High Rounds. I first want to welcome our ID Fellowship applicants who have joined us, and you can always tell who they are with the nice the nice suits usually. We're really happy to have Andrea, Dana, and Ratika with us today, so welcome. And we're also really excited to have an outside speaker who was recommended by Laura Bamford. And today we have Florence Montplaisir. Did I do well? Yeah. Oh, I can say it over and over again because it's such a beautiful, beautiful name. Unlike some other names. Anyway, Florence Montplaisir is an assistant professor in the Division of Infectious Diseases. And the vice chair for diversity, equity, and inclusion in ID, and a senior fellow of the Penn Leonard Davis Institute of Health and Economics. Her clinical research focuses on improving postpartum retention and viral suppression of cisgender women living with HIV and on decreasing racial disparities in HIV prevalence among U.S. populations. She is currently the PI for 2 R01-funded studies focusing on using lay workers to implement theory-driven behavioral interventions to improve adherence to ARVs and engagement in HIV care. Dr. Momplaisir serves as the co-director of the Center for AIDS Research Scientific Working Group, focusing on using implementation science methods to end the HIV epidemic regionally. In this capacity, Dr. Momplaisir fosters the growth of early career investigators interested in work at the intersection of HIV prevention and implementation science research. She also leads multiple DEI efforts in her division, including developing the Penn CFAR Scholars Summer Research Program aimed at providing training opportunities focused on HIV basic and clinical science to students from populations that have traditionally been underrepresented in science. And with that, I will turn it over to Florence. I just wanted to say Momplaisir as many times as I could, but we're pretty casual here, so I will say Florence if that's okay. But I will now turn it over to you.
I'm so impressed, Jill, that you pronounce it exactly the way that I hear it from my native tongue. So I really appreciate this. And because I have my slides in presenter mode, I can't see anyone and I can't see the chat. So if you have thoughts or ideas, I'm okay with interruptions or okay with also taking questions at the end. So I'd like to start by saying that I'm really delighted to be here this morning and to meet you all. The title of my talk is Using Patient Provider Perspectives and Big Data to Inform the Healthcare Transition for Youth Living with HIV. I have no conflicts of interest. I'm not a big wing enough to have any, but I do have a disclosure, which is that I am submitting my dossier. I'm currently an assistant professor. I hope to be an associate professor. And so at the end, I am including a QRS code for an evaluation. So if you could be generous enough to fill it out if you want to, I would really, really appreciate it. So during the next 45 minutes or so, what I'd like to talk to you today about is first describe the epidemiology of HIV among youth and young adults. A lot of you are already familiar with this, but what I really hope to do is to emphasize what's unique about this population and how they fit within the ending the HIV epidemic efforts. And I'm really going to focus on the healthcare transition here, particularly for youth and young adults that are transitioning from pediatric to adult care, and present the results of a pilot grant using the Ending the HIV Epidemic funds, where we applied mixed methods to understand both on the patient perspective, but also clinician perspective. And we included the perspective of a policymaker from the Philadelphia Health Department to really understand the barriers and facilitators to the healthcare transition. And this is to really sort of help understand the context where transition is taking place for youth and young adults in Philadelphia. I'm also going to present quantitative data using a population-based cohort from the Philadelphia Health Department to describe vowel suppression trajectory groups. And this is really sort of an analysis trending the vowel loads over time for this population. And discuss how these results help inform a set of implementation strategies that can be used to optimize the healthcare transition. I'm going to start by just using a slide telling you a little bit about who I am, because I think it helps to inform why I'm interested in this work. So I was born and raised in Haiti, and I realize we all have our own cultural background, which sort of inform the way we see the world. My parents were the first in their family to achieve higher education, and they serve as wonderful role models for me, but particularly my grandmothers, who I saw many times having to overcome issues related to gender-based discrimination and sexism. And so these experiences help to shape the way that I focus on health equity and my interest in women's health. And so outside of this work that I'm going to present today, I primarily focus both my clinical and research on at the intersection of HIV and women's health. And one of the major studies where I'm involved in involves using a peer mentor who is supporting women who are pregnant and postpartum living with HIV to improve care continuum outcomes in the postpartum period. But the reason why I'm saying this is because within the setting where I care for pregnant and postpartum women, I also see a lot of adolescents, not so much adolescents, I apologize, but youth and young adults who are transitioning to adult care. And that's sort of what helped inform the research questions for this pilot. So here I'm going to present two cases that actually helped to inform the research questions that I was trying to answer with this EHE pilot. The first case is a 25-year-old cisgender woman with perinatal HIV who transitioned to me in 2019 in the middle of the pandemic. And her transition was interrupted by multiple episodes of hospitalization. She had been hospitalized multiple times with urinary tract infections and complications from her urinary tract infections, including the development of multi-drug resistant bugs. And she also suffered from moderate to severe depression from past experiences with trauma, particularly with the loss of her mother. She did receive social support from her father. And when she transitioned to me, she had no CD4 count and a viral load of greater than 100,000. The second case is a 25-year-old cisgender man with perinatal HIV as well, who also transitioned to me that same year, who struggled to adhere with his antiretroviral therapy during adolescence to the point where he needed to have a PEG tube placed in order to receive his antiretroviral therapy. His HIV was also complicated by HIV-induced nephropathy. But thankfully, he was able to achieve and maintain vowel suppression a few years before transitioning to me, and also received social support from his father. His mother had also died from HIV and AIDS. So those two patients transitioned to me, each of them with a different set of circumstances, but as you can see, also a lot of overlapping factors. And my question then was, are there ways that I can, based on the information presented in front of me and based on what I know of the inner setting, which is sort of the clinics where they're coming from and coming to, what are the individual and clinical factors that can influence care postpartum, post-healthcare transition, particularly thinking of things that are amenable to interventions that can help optimize care post-healthcare transition. So now I'm transitioning to the epidemiology for youth and young adults with HIV. I think none of you are surprised that youth in general have the worst HIV care continuum outcomes, particularly compared to older adults. This graph shows the steps of the HIV care continuum using data from 13 HIV care centers in the US and using data between 2012 and 2015. And as you can see here, Vowel suppression was only at 12% for youth between the ages of 12 to 24 years old. But the good news is that we know that Vowel suppression improves over time, and this is a robust finding. We know that as youth age to becoming young adults and older adults, that they tend to do much better with Vowel suppression. This study was published in the Annals of Internal Medicine, where they presented trends of Vowel loads over time by specific demographic characteristics. And you can see a dose-like response between increasing age and increasing Vowel suppression. So the good news is that we know that over time, folks do better, which is great. But I think what's a little unclear is, particularly for youth who are transitioning to adult care, how well they do during that period, whether this is a time of disruption for them for their Vowel loads, or whether they are able to experience a transition without much difficulty. Now, all EHE efforts are local, and they require local assessments and the development of strategies that are specific to the context, to their context. And so the Philadelphia Health Department, which is who serves as a partner for this work, created a dashboard for providers where they are able to publicly publish the HIV metrics, particularly the ones focusing on EHE efforts. So here, this graph shows the HIV viral load testing volume in 2019, shown in blue, and then in 2020, shown in green. And as you can see, not surprisingly, during the stay-at-home order, there was a sharp drop in the viral load testing volume, and that slowly increased over time, but did not return to pre-pandemic levels. And it's really unclear during the pandemic how well youth transition, how starting with a low baseline to begin with, how the pandemic affected their Vowel suppression. In the dashboard, they also include specifically all the metrics that the health department is trying to achieve to meet the EHE efforts. And what I really want to focus on is the Vowel suppression metric, which is the last one here, which is to increase Vowel suppression to 95% by 2025. And as you can see in 2020, we're going in the wrong direction, unfortunately, likely due to the pandemic. We don't have the 2021 data yet. But again, thinking of youth living with HIV, and particularly those who are transitioning during this period. And also to help sort of guide the framework for the pilot, I want to take a second to discuss the local context and particularly the landscape when it comes to pediatric care in Philadelphia. So there are 3 large pediatric HIV clinics that care for the majority, close to, I would say, 99 to 100% of youth living with HIV. They're listed here. And what I really want you to understand here is that the model of care differs by clinic. The Dorothy Mount Center is a clinic where care is integrated, meaning that the youth who's transitioning to adult care stays in the same clinic, receives the same care team members that are involved in their care. The only change is that they have an adult care provider, but they physically remain in the same clinic. in the two other clinics, the youth have to transition outside of the clinic. And the population also differs across those three clinics. At the DMC, where care is integrated, they have a mix of youth with perinatal and behaviorally acquired HIV, versus in special immunology, they mostly care for youth with perinatal HIV, and in adolescent initiative, they mostly care for youth with behavioral HIV. And the reason why I make those nuances is because those populations are different, even though they are grouped under youth, but they have different needs and struggle with different barriers. Now, focusing on the healthcare transition, I think most of you know what I allude to by the healthcare transition, but I really want to take a second to describe what it is, both for the context of this talk, but also for research. So the healthcare transition is a purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from a child-centered to an adult-oriented health system. And the goal of the transition is to really allow the youth to engage in care and facilitate the optimal quality of life. This is a model really representing the dynamics when it comes to readiness for healthcare transition. So the patient here is at the center with different levels of maturity. And hopefully the patient is receiving support from a provider and a parent or an individual providing social support to that patient. And they're working together in order to ready the patient for the healthcare transition by optimizing variables that are modifiable, particularly building self-efficacy when it comes to taking their meds, being retained in care, and preparing them for the healthcare transition, aligning their beliefs and expectations with what's coming ahead, establishing specific goals to help them with transition readiness. But there are also other objective factors that are less amenable to intervention, but that are still very important to consider, which include access to care, health insurance issues, and neurocognition. And so this slide is really meant to sort of emphasize the fact that the healthcare transition is not sort of a dichotomous process, it's really a gradual process that starts very early on. And my pediatric colleagues tell me that they really start having a discussion with youth around the age of 12 to 14, help with skill building, help develop a plan that they work on over time in order to really get them ready for the healthcare transition. And for youth living with HIV, at least in Philadelphia, they need to transition to adult HIV care by age 24 or at the latest age 25. This is really sort of mandated by the healthcare systems and by sometimes by their health insurance. So in preparation for this talk, I did a quick literature review just to see what the trends of HIV care continuum outcome, particularly focusing on viral suppression, are before and after youth transition from pediatric to adult care. And most of the studies that I pulled up were from resource-rich countries. And as you can see here in the last column, there's really a mix of results when it comes to viral suppression trends. In some studies, viral suppression goes down, immunologic response actually also decreases, and in others, viral suppression goes up. And in this cohort from the UK, there was high reported mortality among perinatal youth with HIV. There are 2 points that I'd like to make based on this quick literature review, is that the number of individuals included really varies pretty widely from low samples to very high samples. But for the high sample studies, they tended to really focus on youth with perinatal HIV. So I think what's lacking is really sort of a big picture idea using a population-based cohort to really understand what the trends of viral suppressions are for all youth living with HIV. So our aims for this study were to understand the implementation context for healthcare transition using patient and provider perspectives and data from the Philadelphia Department of Public Health. And in particular, we wanted to assess barriers and facilitators to healthcare transition and identify bridging and innovation factors that could optimize the healthcare transition. And bridging and innovation factors are part of this implementation science model that I'm going to explain a little bit more later. And the goal is to use this information to help inform the selection of implementation strategies that could be adopted. So first, I'm going to start with the results of our qualitative analysis. So I use the EPIS framework to sort of guide this work. There are multiple implementation science frameworks, but this one was attractive to me because it helps individuals to think of different phases of implementation when having to adopt an evidence-based practice. In this work, I didn't have an evidence-based practice in mind, and I really focused on the exploration phase, which is really to understand the context in which healthcare transition takes place, to understand particularly the healthcare needs of patients and identify a set of strategies that would be acceptable for patients and providers. So for the patient interviews, in terms of inclusion criteria, we included patients with a diagnosis of HIV who were in care in one of the 3 pediatric HIV clinics that I described earlier, who had established care in pediatric care at least 2 years before their healthcare transition and up to 18 months post healthcare transition. And the reason why we chose those time frames is because we wanted to make sure that they had established care at those sites. Individuals needed to be at least 18 years or older at the time of the interview. The instruments for the patient interviews really focused on barriers and facilitators to a successful healthcare transition, how they felt ready for the transition process, and also describing the transition process for them, whether they had an individual or could identify an individual who could help support or facilitate their healthcare transition. And also we inquired about their perspective on strategies to improve the healthcare transition. For clinician interviews, we included clinical care team members across 3 pediatric and 3 adult HIV care clinics. And as you can see here, we tried to mirror the multidisciplinary structure of those teams within our interview. So we really captured the perspective of multiple team members and also the perspective of a policymaker from the Philadelphia Department of Public Health. Now, this was an N of 1. We were not trying to reach saturation with interviewing this individual, but we just wanted to have a perspective of a leader from the health department. The instrument was pretty similar to that of the patient, but we focused also on the specific role of the clinician in the healthcare transition process and existing clinic resources, which in implementation science, we think of the inner setting and clinic processes that could either impede or support the healthcare transition. And we also asked clinicians to name individuals that they thought were appropriate to support patients through the healthcare transition process. For the data analysis, we use a modified grounded theory for the analysis using both the constant comparative method and using domains from the EPIS framework to sort of guide our analysis. And in addition to that, we asked patients and clinicians to name and rank barriers and facilitators associated with the healthcare transition from most to least significant. So in terms of the patient characteristics, we so far completed 19 interviews. We have 1 more to go. And in average, the patients were age 26 years old. The majority were cisgender women, 93% Black, non-Hispanic, and 67% reported being vowelly suppressed before healthcare transition. In terms of the clinicians, we completed 20 interviews. Half of them were between the age of 40 to 54. The majority were cisgender women, 60% were white non-Hispanic, and 45% had between 11 to 20 years of experience working in the field of HIV. And so here, this slide summarizes the barriers for healthcare transition using patients' perspective. And I have to say that because of time and space, I'm not sharing the quotes here, but I'm happy to share them with anyone who's interested. I'm just summarizing the themes that were included that emerged in the interviews. And I'm also using different colors to sort of help organize the levels of barriers and facilitators. So the yellow represents the interpersonal barriers, and the blue represents structural or process-related barriers. So in terms of the patient, the most impactful barrier was trusting a new clinician, particularly a new adult clinician. And that's really because they had formed strong relationships in pediatric care, and they had to sort of let go of this and form new relationships. And there was some anxiety around feeling judged for their medical history and reluctance to share sensitive information or traumatic experiences that they had lived. In terms of the second most impactful factor was leaving the pediatric team. And that's really because patients had significant and important relationships that were formed with pediatric care team members, particularly for youth who were infected at birth. And communication issues. Patients felt that adult providers had heavier caseloads, they had less time to be accessible to them. They were frustrated because of slow response time and decentralized communication. They really didn't know who to go to for their questions, and this really sort of hindered their attempts to build trust. And then the rest of the barriers were really sort of structural or process-related barriers. So there was a lot of frustration around scheduling the appointments, both because of the process, but also because of the wait time to see a doctor. They went from being used to seeing, or at least being scheduled every month to every 3 months, or sometimes a little bit longer. And also they felt that sometimes the appointment times did not fit their work schedule. They could, in some instances, for example, they were used to walking in and they could no longer do that in some adult care clinics. And also having to adjust to an adult healthcare system where they had to have increased responsibility and increased autonomy regarding a lot of their care routines. And also transportation for some of them, because they had a longer distance to reach their adult doctor's office. Now, in terms of clinician perspectives, the top two really focused on interpersonal level factors, and they were pretty similar to what the patient had reported. So number one was leaving the pediatric team. Number two was communication issues. And then the rest of them were really individual level barriers. So including poor self-efficacy, forced increased autonomy, and the developmental stage. So in general, clinicians felt that some patients were not really ready for the healthcare transition, but were forced to transition just because they met the age cutoff, but didn't feel that they had the maturity to really be ready to enter the adult world, and needed more help with self-efficacy and skill building. In terms of facilitators using the patient perspective, the number one rated facilitator was trusting a new adult provider. So although there was a lot of anxiety regarding forming a new relationship with the adult provider, when the patients really valued their relationship with the adult provider. And they really appreciated providers who made an effort to build a relationship with them, and this helped to build trust. The second most common or impactful facilitator was receiving support from a social worker and case manager. And this is not surprising to any of you, but there were a lot of quotes related to the logistical and emotional support that they were receiving from their social workers and case managers. The rest of the facilitators were really sort of process-related facilitators, including having a warm handoff. And this took place in multiple ways, particularly in the setting where care was integrated. This included just having the adult provider popping in the room to meet the youth who was going to transition to them. In settings where care was not integrated, sometimes when the distance was not a barrier, the adult provider would actually physically come in and meet the youth before they transition to their clinic, or had a video call with them. And the patients really felt that this contact helped leverage the existing trust between the patient and the pediatric team. Having a referral from the pediatric provider, even in the absence of a warm handoff, patients really value the guidance and the recommendation from the pediatric team. And also maintaining a relationship with the pediatric team, even after the transition had occurred, they really felt that continuing to receive support from the pediatric team is something that they valued a lot. And then lastly, co-located care was helpful to them because they were still in a familiar environment post-healthcare transition.
Laura, there's just been a few comments and you're not seeing them, so I want to make sure you're aware of them. Nanny, do you want to unmute yourself and just make the comment about the, scheduling flexibility walk-in, or would you like me to read it?
That's fine. I can unmute. Hi, good morning. Thank you for the talk. I just was commenting that I think that there's a lot of lessons to be learned in adult care from the transitional age youth data. And even, people who are more developmentally complete may not have the life circumstances, may not have the skills that they didn't develop, or may not have the life predictability circumstances to, keep an appointment that was scheduled for 4 months in the future at a fixed time that cannot be moved. And so I think that walk-in concept, or the flexible schedule concept, is something critical for this age group, but really important for us to think about for all of our patient populations, except for the most highly organized and people who have a personal assistant and can keep that kind of schedule.
I totally agree with you. And I think one of the themes that showed up in the sort of preparatory work that the health department had done in Philadelphia for EHE efforts was the fact that they really wanted to decrease barriers when it came to access, including having walk-ins, et cetera. As you know, for adult clinics, it requires a major restructuring of teams and workflows. And I don't know that the health department has been able to sort of move the needle with a lot of this with the adult clinics, but I totally agree with you.
I think it requires some creativity to not just think that, I think what happens is it becomes a productivity perspective of like, well, we've got 8 appointments or 10 appointments per day, and if they're not all full, then we're failing as a healthcare system. And so trying to think about, the fact that you could actually increase productivity and reduce no-shows if you had some spots that were just for flexibility and walk-ins, but that takes some advocacy at the senior leadership level of health centers to really understand that there are different ways to achieve high productivity, especially with more challenged populations.
Absolutely, and I really appreciate this comment. Was there another comment, Jill?
No, other people just sort of agreeing with that, and sort of, it was all around that. Okay. Go ahead.
Thank you. So in terms of facilitators, using the clinician perspective, not surprisingly, having support from a social worker was listed as number 1. And then following that were some structural level facilitators, including being prepared for the transition, having co-located care, providing a warm handoff. What I want to do here is to really sort of contrast what came up in the clinician interviews that did not show up in the patient interviews were really sort of those individual level facilitators having youth being adjusted to their HIV diagnosis and having increased health literacy. So as you can see here, there was a lot of overlapping themes, but on both sides also some unique perspectives that showed up. And I think that's why it's important to be comprehensive in the assessment and include different perspectives, because we all have our blind spots, and it's important to gather all those perspectives when thinking of strategies to help support the healthcare transition. Now I'm presenting specifically the inner context or the clinic sort of factors when comparing and contrasting the pediatric and HIV care and adult HIV care clinics, because these were very strong themes that showed up during the interviews. So in general, the pediatric HIV clinics were characterized as being well-resourced with large patient to provider ratios, and patient developed close and long-lasting relationships with their clinical care team members. And there were also very frequent check-ins where particularly social determinants and social support was provided. Now, the adult care team was also multidisciplinary in nature. However, it was felt that the resources were not present at the same intensity. And particularly, there were some issues related to access to care. When it comes to health insurance, this was one example that showed up multiple times, where if patients were transitioned less than 26 years old and were still in their parents' insurance, that the adult clinical care team could not take care of them because they needed to transition to their own health insurance. And sometimes this created barriers for youth. We talked about the fewer appointments, but there were also comments around the built environment not being as friendly in the adult HIV care clinics, particularly having the rating rooms not being sort of really friendly to youth. So on this slide, I'm sort of summarizing the major themes using the EPIS framework. We address the inner context, which are sort of the clinic-specific factors. The outer context factors are everything else that is not happening at the clinic level. And so not surprisingly to you, things that showed up were associated with food and housing insecurity, HIV stigma, social support, and also issues related to transportation. Now, bridging factors are factors that exist already, but are not used with consistency necessarily, and were brought up during the interview. So things like, for example, the medical record transfer, this came up particularly on the patient end, where they felt that it was important that their new provider knew of them, had access to their records, and were really prepared for the visit. Having a warm handoff, having a network of youth-friendly adult clinics. And this is because some providers felt that some clinics were more youth-friendly compared to others, and helping the patients sort of navigate through those referral systems were important. And also case management models, because in Philadelphia, for example, we're testing a new case management model where the pediatric case manager would follow the youth in the adult clinic for a year after healthcare transition. In other clinics, they had actually a youth case manager who was embedded in the adult clinic. And so there are differing models of case management, but we know that based on the interviews that receiving case management was one of the most important facilitators. In terms of innovation factors, these are factors that are novel, meaning that they don't exist currently, but they came in as new suggestions in the interviews. Some patients felt that having a longer new patient visit was helpful. They felt that during an hour period, there just wasn't enough time to get to understand the culture and climate of the clinic and the resources that were available to them. Sharing provider profiles through an app where the patient could sort of navigate different providers and different clinics and understand how to sort of best select their new care providers. Particularly, patients wanted to have increased health communication through texting. They wanted to access and text their adult provider directly. And this Spacing Pediatric Clinic came from a provider and also from the stakeholder from the health department, where they felt that on the pediatric side, that there was a lot of hand-holding, and one of the difficulty with transition was this abrupt separation in care patterns, and that particularly for those who are already virally suppressed and doing well, that perhaps spacing the pediatric visits would help them get ready for the adult world. Now, when asking the patients and providers about the individual who would help support them during the healthcare transition, both of them listed support from a case manager and social worker as the most important and impactful individual. So now, in summary, pediatric and adult care clinics have differing culture and practices that may serve as barriers or facilitators to healthcare transition. But really what showed up during the interviews is that the interpersonal factors, both in terms of forming new relationships, forming trusting relationships, serve as a strong facilitator, but could also serve as barriers if those relationships were not established. And also, it's important to, because of the differing perspectives that we saw, that it's important to consider all perspectives when determining the set of strategies to be implemented, just because buy-in is important. We talked about, for example, the example with increased access, having the support from leadership and others in the clinic is important. So understanding each other's perspective is really important with that. Throughout the interviews, support from case managers and social worker was seen to be very essential and valued by all. And they were best practices, for example, like sharing medical records that should be done consistently, that were not done consistently based on what we found in the interviews. So reinforcing what we already have as sort of best practices, but testing those innovative strategies that came up seems to be also important. Before I move on, I just want to see if there's any other questions.
There've been a bunch of comments. I was gonna try to save some for the end.
Okay.
I think there is one good question, because I don't recollect you commenting on this either, and I apologize if I missed it. This comes from one of our fabulous adolescent providers, who asked if individuals who are perinatally infected have different outcomes than adults who are infected, or than youth or young adults who are infected later in life. And I'm sorry if I missed.
Yeah, no, that's actually a very good segue to the results of our quantitative analysis. And I'm looking at the time. I realize that usually we have the last 15 minutes reserved for Q&As, but if you don't mind, I'll just keep going and then we can engage in conversation as I go.
Yep, please keep going.
Okay. So what we also wanted to do is to look at objective markers of HIV care continuum outcome pre and post healthcare transition. So traditionally, we use the healthcare continuum, which is a great metric. It's widely used. It helps compare outcomes across different settings. It's well integrated into our EHE goals. But one of the limitations is that it's very cross-sectional in nature. So what we were really interested in is using this Vowel suppression trajectories because it uses sort of the framework of a longitudinal continuum where we're able to trend Vowel loads over time. And that's, Vowel suppression trajectory groups have been used in the literature, both qualitatively and quantitatively. This study was published by Sophia Hassan from Emory, where she identified 3 trajectories for youth living with HIV. Some of them had a consistently engaged in care, pre and post healthcare transition, and some of them had variable patterns of healthcare engagement. This study was published by Dr. Kasai, where she used large cohorts of cisgender women living with HIV and trended their vowel suppression over time. And as you can see, there were 3 different modes of 3 different trajectories of vowel suppression. Overall, suppression increased, or at least having a high vowel load went down over time, but you could see that there are different groups based on their probability of having an elevated vowel load. So what we really wanted to do here is to sort of, in addition to using the traditional health continuum outcome, is to really understand the vowel suppression trends over time for youth living with HIV. And we included youth who transition from pediatric to adult HIV care from the 3 pediatric clinics that I mentioned earlier, and received care between 2012 and 2019. And had established an HIV diagnosis at least 2 years before healthcare transition. And what we did is that we created buckets where we measured vowel suppression over a 6-month period, both before healthcare transition and after healthcare transition. And this helped to inform the vowel trajectory analysis that we used. And essentially what it really is a logistic regression for vowel suppression, where we're able to create different patterns of vowel suppression based on the shape and the trajectory of the vowel loads. And because some observation had missing data, we also did a sensitivity analysis where we created different scenarios of patterns of missingness just to see if they impacted our results. And so for this, the cohort was about 232 youth living with HIV. 69% were between the age of 20 to 24. The majority of them were male and Black non-Hispanic, and sort of really reflected the epidemic locally in Philadelphia. So in terms of the HIV care continuum outcome, as you can see here, post-healthcare transition represented in lighter blue, there was a slight drop in receipt of care, which was defined as having a CD4 or vowel load done in the first 6 months pre and or post-healthcare transition. Retention in care also dropped pretty significantly. Vowel suppression actually went up a little bit, which was a little surprising to us. The trend wasn't significant, but it went up from 55 to 61%. And what was also important, which might help answer your question, is that a greater proportion of those 24 to 25 female patients and patients with perinatal HIV had a higher receipt of care, and a higher proportion of those who were perinatally infected were also retained in care in the year post-healthcare transition. And there were no other significant differences observed by HIV care continuum outcomes. So in general, it felt, at least for our cohort, that those with perinatal HIV tended to do a little bit better when it came to care engagement compared to those who had behaviorally acquired HIV. We identified 3 different trajectory groups when it came to vowel suppression. The first one being high, so the vowel loads were suppressed both pre and post healthcare transition, increasing and also low. What was really encouraging to us is that there was no curves that went down, meaning that there were the scenario by which vowel suppression was high pre-healthcare transition and then dropped post-healthcare transition wasn't a significant one, which was really encouraging. The only factor associated with having a high vowel suppression or being in a high vowel suppression trajectory group was having an age less than 24 years old. And I think based on our conversation with our pediatric colleagues is that usually the youth who transition less than 24 years old are those that they feel are really ready and have the skills to do well in adult care. And perhaps that's why we saw this association here. We performed a multi-logistic regression model to measure the association between belonging in the high vowel suppression trajectory group and other care continuum outcomes. And what really stood out here is that those who were retained in care and vowelly suppressed pre-healthcare transition were those who had a higher likelihood of belonging in a high vowel suppression trajectory group. So in general, if kids did well pre-healthcare transition in pediatric care, they tended to do well post healthcare transition, and those outcomes were measured up to 2 years after healthcare transition because we didn't want to have an overlap with vowel suppression at least for a year post healthcare transition. When we also did our sensitivity analysis with and without the missing vowel load, we actually had a better fit with the curves showing that the missing vowel loads really didn't affect the trends of our results. So in conclusion, we identified 3 longitudinal vowel suppression trajectory groups, low, increasing, and high probability of vowel suppression. Again, we were really encouraged to see that the vowel suppression did not decrease significantly for at least for the majority of folks. But one thing to point out is that the vowel suppression for youth pre and post healthcare transition was still very low at 55 and 61%, which is really sort of much lower compared to older adults in Philadelphia. And although retention dropped post-healthcare transition, this does not translate in a significant drop in vowel suppression at least 1 year post-healthcare transition. And again, youth who engage, who belong to the vowel with a high probability vowel suppression group had a better, greater odds of being retained in care and vowel suppressed 2 years post-healthcare transition compared to those with low vowel suppression trajectory groups. So this overall, although we use a population-based sample, was a small sample of about 232 patients. Other limitations included that there were probably some unmeasured confounding that we couldn't account for, and that the data wasn't missing on random. However, with the sensitivity analysis, there was really no significant change in our results. And also time varying factors such as housing and insurance or poverty level were captured at the end of the pre-healthcare transition year. And this may have resulted in misclassification of these factors during the post-healthcare transition year. But the data was such that we couldn't really do any time varying analysis. So in summary, I think what both the qualitative and the quantitative data did is that it helped to inform a set of strategies that we can consider when thinking of how to best support youth in the healthcare transition. One, age came as one of the variables that were actually serve as a facilitator, particularly for those who would transition at the age of less than 24, but I think it speaks more of the autonomy of patients more than their age themselves. The patient-provider relationship is really important for patients and seem to serve as a strong facilitator. Medical insurance and thinking of, particularly for youth who are under their parents' insurance and thinking ahead about how to solve those barriers is important, but also using data to care strategies. Each of our Ryan White clinics have to report on metrics. They're usually very cross-sectional in nature, and thinking of how we can use longitudinal patterns to sort of help inform our data and our strategies, I think is important, but it requires access to large databases, unfortunately. Case management, again, came up as a strong facilitator, having a warm handoff and increased mHealth communication. So this is my final slide in terms of the discussion. I think that our results are consistent with the published literature. There was a prospective study of 14 clinics from the adolescent clinical trials that evaluated the impact of using a checklist when supporting the healthcare transition for youth living with HIV. And things that really came up as that were included in the checklist actually emerged as facilitators in our interviews. So these included having a transition protocol, identifying a staff person to support the healthcare transition, providing a warm handoff, information about adult clinics, addressing health insurance issues, and the model of care delivery, whether it's integrated or not. And in this study, clinics who applied the checklist with consistency were 5 times more likely to have over 50% of their youth with HIV successfully transition in adult care. And so I'm going to end by going back to our cases that I presented earlier of the female patients with perinatal HIV and the male patients with perinatal HIV. Both transitioned to me, and the female patient who was not virally suppressed post healthcare transition continues to struggle post healthcare transition. And although she sort of became virally suppressed very transiently, is still struggling with viral suppression. And the male patient who had achieved viral suppression pre-healthcare transition actually continues to do well. And so this sort of, those cases sort of really support the data that we obtained from the health department analysis. I'm going to end with acknowledgement from my study team members and study collaborators and our patients. And this pilot was funded by the Center for AIDS Research. And I'm going to end with the slide with the QRS code for the evaluation and see if you have any questions.
So unfortunately, we only have 1 minute, and I really like to try to keep us, I know people have things to do. So there was there's a lot of comments, and you may want to look at them. I don't think we're gonna have time to get to it. There was a question about clinic providing peer navigators. And is that something that your clinic does? I know that it's something that our clinic is working towards. And they've sort of come and gone throughout the years, and I think it has something to do with funding. But is that something that's available at your clinic, and where do you think that fits in general in transitioning age youth?
Yeah, no, that's a very good question, because particularly with my work, I really thought that peer navigation was going to be one of the strongest the strongest factors in terms of the patient perspective. They did not feel that a peer facilitator would help at all. And I think a lot of it is because at least what we found was that youth sometimes didn't want to have high engagement with an individual. They wanted to text. They thought that like low touch interventions and strategies were better or were more acceptable for them. And so none of them rated having a peer navigator or a facilitator as a supportive individual. On the other hand,
that's helpful. And that's interesting. Yeah.
Yeah. And the other hand, clinicians thought that it would be helpful.
I think it also really depends on the patient population, which was something I keep thinking about. Your patient population is very different than what we see here, where we're, our transition age youth are predominantly young, or obviously young, Latinx and Black, gay and bisexual men. We have fewer perinatal youth, although it, you know, it certainly is a group, but definitely a difference there. And I'm sure there are aspects of that that could be teased out. It's 9:01. I think people can stay on. We really need to go. I don't know if you want to look. There were a couple of comments made by Nettie and
We
sort
can
of
just
big
leave it as
comments.
they are. Thank you so much.
Okay, I
Wonderful
just-
talk. People can read them.
I
Thank
just
you
want
so
you to be able
much.
to see these, Florence, just for thoughts for you for the future. And I think because this was saved, you could look back through the recording to see some of those chats. So
Joe, I can send her
Yeah.
the actual saved chat. I get that after.
perfect, but
appreciate
mostly
that.
gratitude right now. So thank you so much, Florence. This is really great. I know as a person who's involved in adolescent to the transitioning age youth, it's a fascinating to hear about this and how we can do it, and it at least makes us feel like we're doing it pretty well here. So thank you for verifying that. But no, your data is really incredible, and we'll have to have you back. And I know there were some people who are going to be emailing you after to get your opinion on some other things. So thanks so
Awesome.
much.
Well, I appreciate it. Thank you so much. Take care, everyone.
Bye,
Thank you,
everybody.
Florence.
Thanks, Laura.
Bye.
Have a
Say
great
hi to
weekend. Enjoy
everyone in
application.
Philadelphia.
Love you.
Bye.
Bye.